Well, thank you very much for inviting me. It's great to be back. Lots of friends and lots of future collaborators and colleagues, I hope, with West of England HSN. So I'm going to start out with a quote from an illustrious American compatriot of mine, General Alexander Haig, who made the very profound statement that the future lies ahead. But I think there are a number of challenges ahead for us, particularly in healthcare, that we've got to actually be mindful of. And I'm kind of setting the scene for what I think the innovation agenda is and why I think we need it. So even though the government, prior to the election, is trying to convince us that the economic recovery is on the way, one thing I can be pretty sure of is that public spending will not increase. It's clearly going to decrease and has been for some time. We're going to be paying back the damage done to the economic system over the years for a number of years to come. So the amount of public money that's going into healthcare is not going to increase. I can promise you. The other challenge, which is a fact that I don't think we can get away from, is that the costs of healthcare are going to go up. So even if we do nothing else other than do what we do now, the costs will increase, or projected to increase in Europe, from about 9% of GDP to about 16% GDP by 2020. And that's without changing anything at all. It's just doing what we do now. So it's pretty clear that our GDP is probably not going to rise by 5% over that time, so we have a major time bomb on our hands. That's something we cannot ignore. So the only way we can do that, obviously we can continue reducing costs, which is what we're doing now in the healthcare system, but that's not enough. We need to provide better care, and the only way I think you can really do that is through innovation. The other big challenge is that our disease burden, if you like, what afflicts us all, is also changing. So that's not a static picture either. Two big problems. One is that if you think about most of the hospitals, and the NHS in particular, was actually set up just after the war to deal with a number of acute illnesses, and that's essentially what hospitals are still kind of doing. But things have changed. But we may be getting back there because things like antibiotic resistance now are major problems that could come and affect us in an acute way. But mainly it's been a shift towards chronic conditions. As a result, for example, of the population getting older, or living longer. So dementia everybody knows about. I don't need to go into the details of that, but it could consume practically the entire healthcare budget by about 2050 if we carry on as we're doing. Stroke is another big one, cardiovascular disorders and others. But clearly, it has a major impact. So those three challenges are facts that face the healthcare system. And what it means for healthcare is I think we've got to rethink about sending people to hospitals and the way we actually deal with the healthcare system. So care in the community and the decentralized healthcare system, I think, is a must. That's something that's going to happen. A more efficient healthcare system. Certainly there's no question in England that we're looking at a huge increase in the reliance of third parties. That means the private sector. So I know in Bristol, for example, already mental health services, 40% of that is run by private companies on behalf of the NHS. And we're likely to see more and more of that actually happening. Whether we like it or not, that's the way it's being dealt with. Smart care, more innovation, more innovative solutions is critical. And I think we need to move, we're going to be moving towards people-centric health. In other words, you and I are all going to have a lot more choice and participation in what we do. We can see that already happening in the US, where they're already at 16%, projected to 25% GDP, which nearly brought the entire government down about 3 months ago with Obamacare. People are having to choose. We don't have enough money to treat everything that you do. You're going to have some choices yourself in terms of what you would like to do. So innovation is needed. It's the key thing that's going to make a difference to this. So AHSNs, Academic Health Science Networks, is a way that the English government has come up to try and improve the ability of the NHS to take up new innovation, and particularly to focus on the adoption and spread part. I'll give you a sort of a 101 on how these different things connect in a minute. But the government decided to decentralize innovation, so not run it from a central NHS England anymore, but to empower local groups to do it. 15 of them have been designated, licensed from September 2013, so not very long ago. We have a 5-year license. They're all roughly based on catchment area. They're all evolving as we speak. And the interesting thing is they're all different. They're evolving completely differently. So we're actually the west of England, not the southwest. Southwest is completely different to us. Wessex, completely different to us. So the way we're doing these different innovation things are based on local solutions, not on any central plan. So why would you decentralize innovation? What's the reason for this? The reason is that if you look at it, quite often the barriers to adoption, that's taking something that you know works in a healthcare system and getting it actually used, are local. There's nothing that you could do centrally that will actually change that. These are stubborn people that need convincing, or people that need educating. So it happens locally, so that's the reason you decentralize it. A central structure actually prevents local solutions happening. If you want a one-fits-all for an entire country, it's quite hard to do that. So if you empower people locally to do innovation, it works. And the other thing that you need in any system is champions, and they will be local. You've got to get the people that are doing it convinced that these things you want to do. So you empower these members to change things. And the key thing also is you need a change in culture, particularly if you're working with industry in the private sector in the NHS. There's a culture change that has to happen. You're not just buying things off companies, you're creating things with them and using your assets to do that. That's particularly difficult for many people in the NHS to understand. And if you're an SME and you've tried working with the NHS, you know exactly what I'm talking about. Incredibly difficult to do that. So West of England HSN, we're set up as a company limited by guarantee. The population we serve is about 2.4 million. Roughly, the catchment area is essentially South Gloucestershire, Bristol, North Somerset, Bath, and North East Somerset. So the major towns are Bristol, Bath, Gloucester, Swindon. And I won't go through it, but these are the sort of 4 key pillar stones of the mission, if you like. And the final point, building a culture of collaboration and partnership, is the bit that I particularly work with is what NHS England is called wealth creation, and I hate that term, so I rechanged it to enterprise and translation, which is what I think it actually is. And so each AHSN has a different set of priority areas. We're not all doing the same thing. So for West of England, the key priority at the moment that we're working on behalf of all AHSNs is patient safety. So that's the one thing that the West of England AHSN is doing on behalf of all the other AHSNs. And I'll give you an example of how we do that with businesses a bit later on. The other areas that we work on, we're particularly good at population health, mental health, and frailty, or the things that are the next level down. So the work streams that we have are research participation, there's the teaching and education and training, service improvement is very important, information and informatics, we're linking up all the health records across there, so you should be able soon to have a completely integrated health record system across many of the areas, including pharmacy, e-prescribing, ambulance service, whatever. When you turn up with your number, we should be able to find out pretty much everything, or you should be able to find out pretty much everything about your own record. There's a patient portal being set up, so you can even look it up yourself. You can have access to your own records doing that. The bit that I'm concerned with mainly is the wealth creation working with industry. I don't expect you to read this, because it's essentially a matrix that was produced by NHS England to show what the different HSNs are specializing in. And you can see the brown one, second from the bottom, are the key things that we work on. So it's patient safety, mental health, and living with long-term conditions. Those are the 3 things that we focus on. On the right are the kind of specialities. So they've looked at all the different HSNs and said, what are you good at? And they said, we're pretty good at biomedical engineering, for example. So that's one thing that we lead on behalf of the other HSNs. We're not that great at COPD, for example. That happens in Wessex. They're better than us, so we let them lead on that. So there's a distribution, if you like, of the workload across different HSNs. So the areas of strength that we have are particularly population data. We're the only people that I know in the world that have genotyped the not yet ill people. So this is done through things like ALSPAC, Children in the 90s programs. These are birth cohorts where we take DNA and biosamples from mothers, fathers, and children that are born in the maternity hospitals, and been genotyping them for the last 20 years. And we've got health records, and they participate in research. Research participation is huge where we come from. And we have an ability to predict, if you like, health outcomes based on that. That's attracting a lot of interest. Everybody has biobanks of diseased people, cancer biobanks, dementia biobanks, all that kind of stuff, but nobody has people that are not yet ill and are able to follow them longitudinally. So many of the mothers who gave birth 20 years ago, their children are now having children. So we have 2 generations. The mothers that gave birth, for example, 20 years ago that were 25 are now 45, approaching 50. Chronic degenerative conditions are starting to happen. Some of them are getting early signs of degenerative conditions. We can backtrack into the children and make predictions of what we think would happen based on the genotype. Nobody else can do that. User participation, I've mentioned that already. A lot of user design, co-creation, some great stuff going on in Bath around that. I mentioned Decipher, of course, that's a major contributor to what we do. I would say it's at least as much Welsh as it is English, for sure. Mobile telehealth, big thing for us. We have most of the telecommunication companies and Silicon, it's a sort of second Silicon Valley in the UK, if you like, after the Cambridge cluster. Robotics, autonomous system, and assisted living, those are big things for us. So where do they kind of fit in? Obviously, basic research is done in the universities. There are loads of clinical research programs as well, run by the National Institute of Health Research, a bit like your NISCR. And those are biomedical research units and centres. You have those in Wales as well. They tend to do the translational stuff. The evidence into practice is done by something called CLARC, which is Collaborative Leaderships in Applied Health Research. And essentially what they do is the evidence into practice. Is there clinical efficacy of this? We've just been given about £10 million to do that in the West of England, something called Clark West. So that's kicking off. That then feeds into the HSN. The HSN is later. It's an innovation that you already know, that you have evidence. This is about getting it adopted and making sure that people are actually doing the things that we already know make a difference. So the HSN is funded for 5 years. We currently get about $2.5 million a year to do that. The funding will go up next year, and then after that we'll see what happens after the election. But essentially, that's the trajectory that we're on. So really, for the first time so I've been in the UK since I won't say, a long time. Yeah, since I was a lot younger. But it's the first time I have ever seen a translation innovation join up, right from basic science to adoption and spread. First time. We have everything in place to do it. There's no excuses now. The funding is there, people are there. It's just a question of putting it into practice. So I'm responsible for the bit that connects up to industry. This is just a little bit of an organogram of how these different kind of things connect. But the key thing is the HSN is very much working with trying to leverage the power of the NHS to commission things from industry, to get things done. And I think, I'll skip back to this in a second. So one way that we do this is through a challenge-led approach. In other words, what we do is we ask our clinical community, what is it that you don't have that you would like from the SME sector in particular, or industry, and then we put out calls. So we have a number of those out at the moment. We just did one recently on patient safety. We asked our colleagues, what are you missing? And they said, well, you know what we're really missing is technology that can monitor when a patient's deteriorating, when they're not actually under the eye of the healthcare system. So the problem is that when people have a condition, say a heart condition, you send them home, they only turn up when they're already ill, back in the system. There's no way of actually monitoring that in real time. So you put out a call. We put up, I think, £5 million as an innovation prize for that. And we said, come to us with your solutions. We had 60 companies turn up. We whittled them down to 10 and dragon-denning them next Monday to find out which ones we're going to fund. But that's an example of how you do challenge-led innovation. You ask for ideas of how you can do things. That's a great way of doing it. And even better, we didn't even use our own money. It came from SBRI and TSB to do it, which is great. So the idea is we're taking ideas from everywhere. A number of Welsh companies, in fact, have even participated and are participating in this. Take any ideas that they represent the challenge and prioritize them. And then we fund them to deliver solutions that we need. It's a way of doing challenge-led innovation. So being challenge-led is our first priority. We're also working with the regional partners. In England, we have these things called local enterprise partnerships that are responsible for business development in the region. So what we're doing is working with them to see how we can connect up the SME community and get them using the facilities that we have in the NHS and in the universities to make better products and also to advertise them, the kind of things that we do. So there's a lot also about culture change, partnering with industry. You can read the bits and pieces, and we're going to go through it all. Adoption and spread, sort of mechanisms that you do that. So those are all kind of key priority programs. But it's about identifying, selecting, adopting, and then spreading that. So it's about using the NHS and the power of the NHS, Our commissioning budget in Bristol area alone is in the billions. So it's essentially using that power to draw things in and make better products, better healthcare. I did say if I had time, I'd go a little bit into some of the open innovation and translation ideas. Do I have time to do that, Keith? 2 minutes, okay, very quickly. So clearly, the idea of doing open innovation is very important and I think fits very much with the NHS's philosophy. The idea that ideas can be generated anywhere, by anybody, is great. So putting out challenges, they don't have to come from your lead clinicians, they can come from people doing everyday things. So we have a number of systems for doing that using crowdsourcing systems. But it's pretty challenging once you start moving this into some other sectors. So particularly in the academic sector, I find this very difficult. Because they don't really like to share ideas. They like to actually do things, be a bit secretive and publish them and get grants. So it's quite a tough area to do for academia. But in the healthcare sector, it's a little bit easier. You're building teams to solve problems and get on top of them, do those kind of things. So I think it's a real goer. But it's a lot about kind of building this ecosystem. Some of you may have seen this slide many times. I've used this often in the things that we do. So this is really stuff that built out of the work that Corinne and I did around SARCH in terms of how do you build an ecosystem going from the sort of NHS to adoption and spread. So on the one hand, you've got industry people, you've got clinical practice coming up with the ideas, universities and the NHS can also come up with the ideas, and the community that really needs the adoption and spread. But these guys all have different cultures, different drivers, different languages, different timescales. It's how do you make all that kind of thing work? And that's very much what we've been about, and I think the HSN, if you like, captures that for the translational medicine bit, and some of the other structures that we have capture that on the translational research bit. I can stop there if you like.